welcome everyone. So thank you for attending today. So my name is Desi. I am a first contact physio and one of the AHP NATH ambassadors alongside Laura. So I'll hand over to you.
Hi, my name's Laura. I'm also a first contact physio based in Newark, and the other half of the ambassador team with Desi.
Then we have the lovely Sarah. You can introduce yourself.
Hi, my name's Sarah Partridge. I'm a clinical pharmacist by background, and I'm here as I work for the multi-professional support unit that works as part of the training hub.
And Kate.
Hi everybody, I'm Kate Knowles. I'm the ICS Advanced Practice Lead, an advanced clinical practitioner by background, but not been practicing for now, probably getting on a year and a half too. Hence me being a little bit nervous, Desi.
So I'll put it out as the first bit. This is a safe space, and what we're trying to do is, back in the days we used to be able to speak to people more face to face, whereas now we're in a more virtual world. So it's having that opportunity to discuss some of the more common things that we see in primary care, and share kind of what is best practice in the primary care environment, and also what are like the local Nottinghamshire procedures. So today's focusing more on head and neck pain. I put first contact practitioner because even things like headache versus neck pain might come to a different clinician, but it's that we've all got awareness of what we could do or who might be the better person to assess further. So please, you can turn your mics off, you can write in the chat. We will bring about some cases and then have a talk about them, a chit chat. So now working this. So I'm sure we can all use Teams, but please, as I said, just send a message or unmute yourself. House rules. So again, we're here to share best practice. Please feel free to contribute and treat each other with respect. So we all have different opinions, so be nice to each other. Just again to introduce, so from the allied health professional roles, we're here to support the 5 AHPs. So physios, OTs, dietitian, paramedics and podiatrists. So if there's any concerns with or queries about education, career development, that is what we're here for. So you can speak to either one of us. And that the reason why I say that is because we all wear different hats. So depending what you ask us as to which hat we're wearing. And just to update, we have the Allied Health Professional Conference on the 5th of June, which is online for all first contact practitioners from GPs, AHPs, nurses are all welcome to attend. We've been going off the training need analysis to do topics that you've wanted. So we've got the neurodiversity specialist team coming in to talk about autism and about that referral pathway and what you can do in primary care. The top 5 medications or top 10 medications by the lovely Sarah, and menopause, alongside treating the unwell mental health and acutely unwell patient. So lots of information, so if you can come along, you're more than welcome. And then we're having more of a chit chat session next month, but looking more at chronic and widespread pain with representatives from the pain team from City and from PICS covering the rest of Nottinghamshire. So let's get started. So when we go through these cases, you're going to think, if they've come into your clinic, what do you want to know about? So subjectively, what are the kind of things are you going to question or look on your note system? Then what is that going to do to your objective assessment alongside what you might investigate? And then obviously if there are queries, that's where we can discuss how kind of different areas of Nottinghamshire and what pathways or investigation procedures. But as I said, please question away. Let's challenge each other. So I'll hand over to Laura.
Hi guys, so the first case study is a 40-year-old female with a 6-month history of an occipital region headache. We know that she's got a desk-based role. She can kind of do everything. She's got no functional limitations, but obviously this headache has become intrusive on her life. And she has tried some paracetamol and some NSAIDs, but with no significant benefits. So we just wondered what you guys might ask subjectively if this patient presented to you in clinic. I appreciate that everyone has their cameras off, but feel free to pop them on if you would like to. And please feel free to add what you might ask if this patient came to you Oh, perfect. So more details about past medical history. Yeah, someone else said about wearing glasses. Yeah, great questions. So I think certainly from my perspective as a first contact physio, if this patient comes to me, then I'm going to be screening to make sure that they're appropriate for me. So making sure that the patient's generally well, that there's no kind of associated fever is really important. Finding out how quickly the headache has come on. So if this is somebody who's rung in the morning with a headache and you're seeing them in your morning clinic, if it's kind of very rapid onset of a very severe headache, again, that one's probably not for you. So the advice is that if somebody has a headache which comes on really suddenly and reaches a point of very maximum intensity by 5 hours after onset, that patient should go on to kind of further investigation. So that's the kind of patient you would probably be sending on to A&E. Finding out whether there's any yeah, great question. If it's a familiar headache, if it's a headache they've had before, really good point. Obviously, those unfamiliar headaches are the ones that we're kind of more concerned about. If there's any associated cognitive or neurological deficit, really important there. I think Sarah's just popped in about any recent trauma. I saw a message flash up about being hit on the head by a golf club. But yeah, any kind of recent trauma, really important. The other thing which is in the NICE guidelines, which is actually something new to me, it's not a question I would have asked before, but if the headache is, obviously I will now, if the headache is made worse by a cough, a sneeze, or like the Valsalva manoeuvre where you close off the nostrils and blow out, and so if that increasing pressure increases the headache, that's kind of something that needs further investigation. Also, if it's been triggered by exercise, so if the patient's noticed that the headache is triggered by exercise, that's something that would kind of need further onward investigation. So is there anything else there that I haven't mentioned that you guys might ask? So
I would ask about sleep disturbance in terms of pattern of pain in the day, just for this one especially. So if it's on for 6 months, there might be some sort of pattern.
yeah,
Any rash?
yeah.
And in terms of the pattern, are they coming in clusters?
Yeah. So that kind of cluster headache pattern is really important, isn't it? We are assuming with this patient that the answer to all of those questions is no. So no concerning features to this headache. So we can move. Oh, Sarah had a question. Yeah, please.
I was just saying if there's anyone in the house with a headache pattern as well, because then
Yep.
you're ruling out carbon monoxide poisoning.
Yeah, very good point. Yeah, really good, useful, helpful thing to think about. I think actually the other thing that I haven't touched on here is a little bit more about kind of potential stressors. So a bit more about situation at home, situation at work, and whether once you've kind of ruled out any of those more kind of biomedical causes potentially for the headache, thinking more about kind of the social situation and potential stressors. So moving on to, oh yeah, TMJ, somebody's just mentioned, yeah. So kind of more for like tension type headaches, and like obviously jaw pain is significant, but also with kind of tension type headaches, anybody who's like a teeth grinder might have been picked up by a dentist is quite significant, because that kind of TMJ, sternocleidomastoid type pain is quite closely associated.
Surprising amount of people that actually, I asked them, like, do you know if you grind your teeth, has your partner ever told you that, or if you're stressed you bite down? And they're like, yeah, like I used to have a bite guard but I don't anymore because I can't find it or anything like that. But that's something I see or hear more often than I'd expect.
Yeah, I think teeth grinding is quite common, isn't it? So in terms of an objective assessment, kind of again coming more from sort of a physio perspective, we would always do like a neck range of movement assessment, so looking at whether somebody's got kind of full range of movement. Particularly important is their rotation range, because rotation comes from the upper cervical part of the spine, and cervicogenic cervicogenic headaches are associated with the first 3 joints in the cervical spine, which are the joints that are responsible for cervical rotation. So if somebody's got really, really limited cervical rotation, that could be a very good indicator that this is more of a musculoskeletal headache in origin. Also just kind of having a little look at wider sort of shoulder function, thoracic spine function, neurological examination. Obviously this could be cranial nerve examination, as well as looking at kind of upper limb neuro examination, and then again just that review of kind of stresses in the psychosocial situation. So people's sleep pattern, people's responsibilities at home, caring responsibilities, work situation. Oh yeah, Kate, really, really good point there. Blood pressure. Yeah, very quick thing. And again, kind of, I think from a kind of physio perspective, when we're presented for somebody with blood pressure, we probably look more for a musculoskeletal cause, whereas obviously taking the blood pressure is something you can do super quickly and really important, isn't it? Because if somebody presents with really, really high blood pressure, then they need to be kind of straight out of your room and in to see somebody else.
Also having a look at their notes, if they're known to have hypertension, or if things have changed, has their medication changed, are they under the GP already for a similar issue? Is it this is probably more Sarah's remit, has a medication change and then headaches come on?
Yeah, I think other things that I would look at if this person presented to me was just a little bit kind of muscle tone, like the key muscle groups around the neck and shoulder that would often refer into the head, kind of thinking about the sternocleidomastoid, the upper trapezius, kind of having a little feel underneath of like the scalenes if they're particularly tight, looking at kind of how somebody's breathing. Maybe, you know, if you've got somebody who's like a real like apical breather, short of breath, they're much more likely to have that kind of myogenic tension. Having a little feel of the tension in the suboccipital muscles. I'm not sure whether we really use the term trigger points anymore, but kind of, you know, seeing if you can find any kind of sensitive spots within the muscle, particularly if you find something that reproduces the patient's pain. Obviously that's such a powerful reassurance method. If you have managed to palpate a point or locate a point within their muscle that recreates the headache, that's going to give them a real reassurance that it is kind of a muscular referral and nothing more severe or sinister. And then, yeah, just kind of general postural assessment and having a little chat with people, particularly with so many home workers now, having a chat with people about what their homework desk situation looks like, whether they use a laptop riser, desk, all those kind of simple things which might have been available to them in a workplace, which now isn't available to them now that they're working from home. So I probably should have asked this question before I move on to the next slide. But so this headache is a primary headache that would fit into the tension type headache or cervicogenic headache category. So this is one that would be kind of totally appropriate to be seen by an FCP physio or to be referred into a physio service. So generally they're characterised by bilateral pain, which can be described as either a tightening or a pressure. A key thing is that the quality is non-pulsating. So if somebody comes to you and says that they've kind of got this pulsating kind of headache, then it's very, very unlikely that it's a tension type or a cervicogenic headache. And also it would be associated with no other symptoms, so no kind of light sensitivity, no visual disturbance, and no kind of nausea or vomiting. So, and the structures that can cause these kind of headaches, they can come from the upper cervical facet joints. They can come from the like muscles that connect between the neck and the shoulder. Also from the intervertebral discs or the nerve roots. Those structures can all refer up into the head and could cause headaches. So I think just kind of really making sure that you've done a really thorough subjective assessment and ruled out anything that could be could mean that it's not a tension type or cervicogenic headache is the most important thing really for us. Once you have decided that this is the category of headache, there's evidence to suggest that postural re-education, exercise, stretching, massage techniques, heat, and also acupuncture can be really helpful. I think acupuncture is something that used to really regularly be available in sort of pain services and physio services. It isn't really now, but obviously 10 sessions of acupuncture for tension type headaches is recommended in the NICE guidelines as one of the treatment options. So, you know, that is something that somebody could seek out privately if they kind of have exhausted everything else. So kind of this type of headache is something that as kind of physios, FCPs, we could certainly give some help and advice to. I think we'll move on to the next case unless anybody. Kate here says that her brother had exactly the same last year. Oh yeah, thought it was going to be high blood pressure, but turned out to be fixed with kind of workplace changes. So Sarah was asking how often this type of headache occurs. So there's a diagnostic criteria. So if it happens on more than 15 days of the month, you would class it as a chronic tension type headache. If it happens on less than 15 days of the month for 3 months period, then it would be episodic. But it can be quite frequent. I think generally these kind of headaches are better in the morning. So I think, you know, rest and sleep overnight makes the headache better, and it tends to be worse through the day. And you know, when people are tired, when people have been sat at their desk for a long time, when it's cold as well, I think just that's not evidence-based, that's just something that I have experienced. People tend to find obviously they're cold, the postural changes, but I think, yeah, this kind of headache definitely shouldn't be a consistent, constant type headache. It should be a headache which is better when people are walking, when people are kind of active, when people are away from their desk, when people have had a sleep, and they should notice that it's worse with sustained postures, maybe with driving or reading or computer use or carrying shopping bags or something like that. You know, they should be able to recognise some kind of pattern when it occurs.
I think that's where I see a lot of these with neck pain that then have this headache more as the secondary. And actually I've gone a lot more into, say, the stress management side, because generally there's not one. A lot of these people will say, I don't know when it started, it kind of progressively come on. So it's, and I say to people, it's normally just not one thing. That's the thing with these kind of neck pains. Our head is the heaviest part of our body. Our neck has to work really hard all day long. So is it that you've changed your posture at work because we work from home? Is it that life's a bit more stressful because of outside factors? Is it that again, like you said, it's cold? Yeah, so I think it's I say to patients, like, look at the big picture, and that's going back to the real basics of sometimes it's, can we help with that mindfulness work? It's identifying what is the trigger. We can do all the brilliant rehab in the world, but if we're not identifying the true problem, that it's stress at home or stress related work because they haven't got enough staff, for example, and this is, if Bags is still on the call, probably the bread and butter of what pain team do with these patients.
Great.
Yeah, so sorry, I am with you. Yes, absolutely. I think with these sorts of headaches, there's a lot of breathing control that's important, and working out how to calm their central nervous systems, and that consciousness of, particularly as so many of these are myofascial, so much of this is upper trapezius, sternocleidomastoid, the suboccipitals that go into that classic posture. Sorry, I'll just get on the camera, that kind of thing, or that kind of thing. So anything you can do physio-wise to help people relax and breathe, but also anything in their life that they know helps to soothe and calm them, and that will be hobbies and activities, daily activities that they do, family members, people they know that calm them, and addressing all their work and lifestyle activities. So it actually becomes huge and very holistic when you're managing these people. Yeah.
Yeah,
thank you, Mags.
Yeah, that's a great contribution. Thank you, Mags.
And for those who don't know, this is Mags Wigram, the amazing pain specialist for
Yes, no, thanks, thank you. But yeah, I think I feel a bit humble. I don't feel amazing most of the time.
She is, I can tell you
get such challenging patients, I'm sure.
Perfect. So we'll move on to the next one. So we have 55-year-old male who last week said he was in a road traffic collision. He was the driver, 40 miles per hour. He was the one in front and shifted from behind. And since there was no pain at the time, but the next day woke up and starting to get more neck related pain. Works as a forklift driver, and at the minute he can't work because pain is too significant. Thoughts? So what do you want to know more about? He did not attend A&E because it will just get better on its own. Chuck a paracetamol in, it should have been better by now.
I think given the trauma, you'd perhaps be thinking a bit more about kind of your concussion type symptoms.
So good. Any referred symptoms? So nothing going into arms, legs, no tingling. It's all at his neck. And no, his pain's getting worse, and that's why he can't go back to work. What else do you want to know about the actual road traffic? So are there any, so loss of consciousness. So no, there was no loss of consciousness. No red flags. So he got hit from behind. So he was the driver, a car hit him behind, and they were both moving, but obviously he got shunted forward. What else in RTCs do we generally ask as well? What can paint our picture? So concussion, how do we diagnose a concussion? Ongoing claim, very good. Yes, I like that. Are they putting in a claim? Yes. So let's put in those psychosocials in there. So things I normally ask as well is, were they wearing a seatbelt? Did their airbags go off? Almost what happened at the time. So be it like you're saying, are you putting in a claim in? Have you sought any other medical attention or put in insurance? Because that's what I've had people at the end like, oh, can you print off my notes now? Because I need to send that off to prove I've got an injury. So a bit like we just said with MAGs, there's a lot of sometimes psychosocial elements that can factor into these. So I go on to the next one. Yep, exactly that. Stress and PTSD. So what actually happened? Has there been previous instances before? Headache, nausea, so loss of balance. So yes, no red flags in this case for neck, just the pain. So I think we've answered. So we had no investigation. Back a headache again, no clear injury or head, or that's what we're saying, head injury or concussion. And kind of what is he doing at the minute? So at the minute he's just popping some paracetamols and not gone to work, but it's been a week, so he needs a fit note. So assessment wise, so again, similar to before, is kind of from our physio perspective, it's making sure that we've ruled out more than nasty things. It's checking a little bit of history before. So has he ever had head injury, previous kind of neck injuries before? Did he get headaches or neck pain prior to this accident? What can he do? So again, I always say, like, what can you move? What can you do? Any functional limitations? So it's more, if you say like a forklift driver, it might be that concentration element. It might be just those sustained positions. It might be the dexterity work, for example. So appreciate we are not all in sport. But there is the SCAT, which is Sport Concussion Assessment Tool. So it's not that to do the full assessment, and appreciate this is really small. I can add it in the chat in a bit, the full document, but one of the pages, it actually asks for symptoms, and we ask kind of, so it's mild, 0 to 6, so no to severe symptoms. That's kind of the scale. Since you've had your head injury, how severe have these symptoms been? But it's hard with some of these because in sport we always do a baseline of what their normal is. So if you normally have a headache now and again, and you have a normal headache now, is it any different? Or if it's like, I normally never have these symptoms and now I'm irritable, I can't sleep, I feel like I'm in a fog. So those kind of questions where some people might not realise that they are signs of a concussion. Now we can only say concussion when we've ruled out that it's definitely not head injury. So at the time that there's no kind of again, true head injury symptoms, that there's no neural symptoms, there was no almost like tonic postures, no loss of consciousness, which should have all happened at the beginning. So in sport, that's probably where someone gets knocked out on a tackle. That's where you look at that, but we can't say, oh, that's a concussion right there. You have to wait until a head injury has been ruled out. The fact that this guy is still functioning, lower risk, but that's where your questions of kind of these red flags, is it that they need to see a GP, an ACP, or be referred on for potentially headaches. At the minute, we're still in neck, but it's just making sure that you're aware that you've got a tool like this which can just guide some of the questions. And again, in sport world, what I found that in my primary care role, we don't ask these questions so much, where people are functioning relatively high, not enough to say that they've got a head injury, but kind of the concussion side. How can we manage people that are in active physical jobs? Any questions on that? So it's just a tool, and part of this SCAT tool as well is they look at testing. So you look at time, place and space. Again, that's something we commonly do. It looks at immediate memory and delayed memory, and at, I can't remember what you call it, but basically you say numbers and they've got to repeat it back. Then they do some physical tests as well. So it's looking kind of at that upper motor neuron work, balance. So it's quite a nice test, that not that you're going to do all of it in a primary care, but things to consider when we are looking at like a post RTC. So it doesn't actually have to have loss of consciousness to be a concussion. I think only 15% actually lose consciousness. That kind of counter coup is an ability to get a concussion as well. They don't have to have a direct blow to the head. So it's just being aware with whiplash, especially wearing their seatbelt and they get thrown forward, that could cause these kind of symptoms. So management, so things I would look at is obviously looking at their med 3. So are they safe to work? So he works in a forklift. Has he got the ability to safely drive a vehicle? What can we put in place? So could he do lighter duties, but he's not yet safe to drive the forklift truck? What rehab can we give? Is there any kind of pain management advice that we can give to support him as well? And obviously very similar to what we discussed on the previous case, but then just adding on. Any other thoughts from other people? All good. So next one, 75-year-old female, sudden onset, temporal headache, severe pain, and just really under the weather this week, but then woke up this morning in really severe pain. You have a space in your diary, whatever profession you are, so it gets thrown in your diary because it's busy. What is your first thought? History of PMR, good. She does, yes, we'll give her that. No, she's had a history of it, but no recent intervention. No trauma. Scalp tenderness, yep, she's holding on because it really hurts, especially on one side.
Whether there's been any visual loss?
It's too painful. She has to close her eyes because it's just so painful. And she just feels really grotty at the minute. What is everyone's instinct? Correct. Yep. So, yep. Next thing, we'll look at temperature rash. But if we're looking at GCA, so vision changes, weakness. So again, if there's any neurological symptoms, past medical history, it's exactly like PMR or anything inflammatory. So yes, it's just making sure aware if we do getting these headaches. It's generally an urgent, well, it's not generally, it is an urgent referral to an eye casualty with any suspected signs. So we're looking at that temporal headache, that scalp tenderness, anything of that jaw claudication, neck pain, any weakness. So looking at a bit of neural symptoms, loss reduction of vision, double vision, or raised ESR. Who is going to wait for a blood test before sending this off?
Mm-hmm.
Hopefully no one. So this is on here, and I'll put the link in the chat as well, is the getting it right first time, is that it goes to an eye casualty, and generally you can always do a call to on-call rheumatology. So in Nottinghamshire, again, Sarah might correct me if I'm wrong, is, well, here's the pathway, and if you can see that, of how people present and where they should go. So this is the getting it right first time pathway, but they should go to an eye casualty and they'll be under rheumatology pretty quickly. And if I go back to, and the general treatment is that they're going to be on oral steroids, and that's where they'll need further investigation from the ophthalmologist. Anything from anyone else?
If you're going to put them on oral steroids, that side, you might want to consider a stomach protector.
There we go. This is why we need your specialty as well. Kate?
This used to be something I used to see a lot in medical admissions, of people sort of being referred in because they came to us first, which wasn't probably the right place, because then we would have to organise getting them to these two places. And so this was before this getting it right first time stuff came in. But I cannot overemphasize the urgency in terms of getting people in and obviously onto the treatment quickly. I was thinking, oh yeah, okay, yeah, it's the next day and it's all okay. And it was the rheumatologists that really ingrained it into me, is that no, it needs sorting out now. So yeah, nicely done. Thank you.
And I guess it depends what profession you're in. So as I would say, the MSK side of it, get them either to the on-call GP or onward to rheumatology or eye casualty ASAP. It's not, I probably wouldn't worry about testing, like looking at neuro. If I've got those symptoms, I would just send it on. So again, it's what each opinion is. I think if you've got enough of a gut instinct, don't pass go. Okay.
May I ask what you say to your patient when you're referring them?
So I would say at the minute I've got a suspicion of this. I'll check with a GP, because I would always go through an on-call GP in my practice, because generally it would be better going through them. So but that's what I would say. At the minute with these severe headaches, I think it needs immediate treatment, and therefore I would like to get a specialist opinion. I've only had one since I've been in primary care, of a true one, and they were more than happy to be getting seen ASAP with a severe amount of pain.
So this is just a really good question, and it doesn't mean answering now, but it's just one to put there, because this is a headache conversation. But this is a tricky one for you guys, isn't it? Because what you don't want is your patient to say, oh yeah, I'll get my own way into hospital, and because the person has been lovely and has not has not wanted to really scare them, they've not said it needs to be now. So it's that real balance, it's that really tricky balance between scaring the EBGB out of them and saying you need to be there, and making sure that they don't leave it for a couple of days until they can get their son to come and pick them up.
Anything else? Any other? So I'm just putting the links in now. Yep, as Laura said, 3 times more likely in women. So have I put that? So here's a nice paper that rheumatology has advised on guidelines and the way the process that they follow. I've just put those in the chat in terms of that pathway, and that's where I said, depending on your profession, I think exactly what Kate said, a very good point. Sometimes scare the heebie-jeebies then of saying how urgent it is. I generally, as I said, would always go to a GP, because I know in referral patterns that if you're a non-prescriber, that's where it can sometimes be a bit of a barrier. That's just what I found. So even from DVT, the one case I had, I just went to GP who called it straight in. But it's just considering that. Have you had any, Laura, from your experience?
Touch wood, no, I haven't.
I do not wish one for you this afternoon.
The only other thing I would add, and this is just something that came up when I was researching for today, 25% of cases, the patient already knows that they've got polymyalgia rheumatica. So I thought it would be more, but yeah, so kind of 1 in 4 that you see, they'll already probably be on treatment for PMR, and then this happens.
Hand over to Sarah, please.
Brilliant. So for this case, we've got a female office worker who's been experiencing headaches over the past 4 months, which was kind of only a headache once every couple of weeks. But in the last few weeks, they've ended up having them continuously, like on and off, and ended up taking 4 days off work. They're not prescribed any medication, and they've got a clear history of migraines. So what kind of further information would you like to know in this case?
If they've got any kind of headache diary, maybe that would be really helpful.
Yeah, so you'd like a headache to see the triggers, patterns, any hormone change it could be. So asking where it's happening in relation to their period, that's a really good point. Anything else?
Any lifestyle changes?
Yeah, we could ask that. Would anyone ask anything else?
Food triggers, maybe?
Yeah. So apparently for this patient, they get it after a long day at work, they get the pins and needles in their hand, and then the headache will start within half an hour.
What have you done to manage it so far?
So she'll often go to bed and close the curtains, and after a while it might get better. Is it similar to migraines or different? So she has a history of migraines. There's been no change other than it's happening more and more often. No particular changes in mental health. So would anyone ask anything else with regards to medicines?
What do you take over the counter if nothing's prescribed, if you do?
Yes. So it's really important in patients with a history of tension headaches and migraines to get a real history of over-the-counter medicines. So we're thinking over-the-counter cocodamol, because you can get a low-dose codeine and paracetamol. They're paracetamol used. You can get the non-steroidals. So in this patient, she's regularly taking cocodamol over the counter, which I think is the highest selling over the counter medicine, and she's taking it 3 or 4 times a week, and when 3 to 4 times a week, sometimes if she knows she's going to have a busy long day at work, she'll take it in advance. So yeah, you want to know headache pattern, triggers and current management, particularly including over the counter medicines, and sometimes you have to specifically ask that because patients don't always readily tell you about it. Should we go to the next slide? So what assessments would you do? Well, I wouldn't do a cranial nerve assessment, but I assume that some of you guys can do that.
I guess it's more when you say pins and needles and hands, that's where I think in MSK world would naturally want to do a neuro assessment to make sure there's not a neural component.
Brilliant. I would have to refer to you guys because I can't do that. But yeah, I would always ask advice and things like that. I would check the blood pressure though, to rule out that if the blood pressure was continuing worse, and check on the eye. Do you, within your scope of practice, do you check fundoscopies at all, or do you refer?
Not in MSK, but again, potentially ACPs. Kate, you'll be able to answer this more. Some nurse practitioners, paramedics may.
It might be more sort of the advanced clinical practitioners, and it's places where fundoscopy will be being done quite often. So it's all very well getting taught and trained and you're okay, but you need, it's a bit like reading ECGs. You need to be doing it, and you need to be doing it all the time. So there are certain areas where fundoscopy is done, and there may be some practices where people do fundoscopy because they do actually do it quite a lot. And then there are other areas where people are not, but there should be somebody within every practice, within every area, that could at least look for the basics and be able to have a look.
Yeah. So we've always been taught, because I manage high blood pressure patients, that they need to go to the opticians to make sure they've got a regular up-to-date eye test. That's our way around it as a general rule, if there's no red flags.
May I just come in there, because that's a very good point, Sarah. And sometimes that question is not asked. So actually, have you had your eyes tested just recently? Is a really good question, because that often gives you a really good answer straight away. Oh yeah, I did. I didn't think that would be important. And I had it done last week and they said my eyes were fine. And that means that you can already do that, a big tick on that. So yeah, well, good point.
So yeah, and the other thing is a lot of opticians are now testing blood pressures as well, really interestingly. So because I got offered mine when I went, so you could, just by asking that question, you could kill a number of stones with them. How often people should have eye tests, that depends, but it's normally every couple of years for someone with no real issues. So yeah, Nat's asked that, answered that. Thanks, Nat, for helping me out there. Brilliant. So you've done all the assessments, you've not revealed any red flags, but you have revealed they are regularly taking cocodamol about 20 times a month. So what could the potential diagnosis be here? Which is the most likely? So it's looking like it's a migraine. It's looking like they're using medication regularly to treat that, but that migraine is still happening and it's having an impact on their day-to-day life. So what's the diagnosis potentially, and what are the differentials?
We give the hint that Sarah, the pharmacist, is leading on this one.
Yeah, big hint, because I can't do all the assessments, and but it's just to kind of highlight.
How quickly Mags can write.
Margaret's writing. I think she's going to get it. I have my confidence in her.
Yes.
So
you're going to touch on that anyway. And now,
yes. So it's looking like if you've ruled out other causes, it's likely to be a medication overuse headache. So the definition of this is headaches that occur on more than 15 days per month. Also, that patient should have a history of a primary headache. So they've already got a diagnosis, and then it gets worse, and it kind of it presents more and more often because of that regular use of medicine. They've got to have a history of regular or overuse of acute headache medication and things like that. You also have to rule out there's no other causes. So you just want to assess and check on that. And actually differentials could be chronic tension headache. So as was it Laura that touched upon, so you could have a headache that becomes chronic because it's been over 15 days. So just that could be the differential. And I suppose rule out any of the red flags, so the thrombosis, the intracranial hemorrhage and things like that. So the medications that you need to look out for medication overuse headaches are the over-the-counter analgesics, so the aspirin, the paracetamol, the cocodamol, the ibuprofen that you'll get from the non-steroidals. Other analgesics can cause it, so if they've got any prescribed, that could be a cause. Also look out for the triptans, so the sumatriptan and the zolpidem, they all end with triptan at the end. That's the big giveaway. And also think about caffeine-containing medicines. And there is a question mark over the evidence for like cannabis and cannabinoids, so you might want to explore recreational substance use. Depends how much you can build that trust and things. So don't rule out the use of recreational substances potentially causing that as well. But the evidence is not as strong in that area. Laura?
So we know lots of people now are using like CBD products, so the legal CBD products that they're buying from health shops and things. Is there any association between the use of those and headaches, or would it just be?
Good question. I don't know. I will go away and put a link in this chat about it. And
well, it's all quite new, isn't it? So I guess it's only kind of in the last couple of years that those sort of products have been available.
Yeah, so it doesn't, and also because they're kind of a herbal product, it doesn't undergo the most robust evidence and trials and things, so you don't have as much information out there. But I'll go away and have a look. I mean, the problem is if you look at all the literature for medicines on side effects, you're going to get headaches listed. I don't know of a single medicine product that doesn't have headaches listed as a potential adverse drug reaction. And also just bear in mind, women are more likely to have adverse drug reactions than men as well. So I think it's like almost 50 to potentially 75% more adverse drug reactions occur in women. So which is interesting. I recently went to a presentation on that, and I want to dig it out and perhaps look to recreating something like that within our area. So watch this space. We looked at the other cases, and often it's find out what medicines they've had. Has there been a change? Is that medicine associated with headaches? So these are medicines commonly associated with headaches. So you've got the hormone contraception. Nitrates are a massive cause. And with GTN, that can actually be quite reassuring because you know it's working if you're getting the headache and you're relieving that angina pain that they're getting. But if you're on the tablets, nitrate tablets, then having a headache every day is probably not a good thing. Other ones could be sildenafil, tadalafil, which is used for erectile dysfunction. They can cause headaches. And again, that's probably not ideal. Some of the blood pressure medicines as well, particularly the calcium channel blockers, can cause headaches. And I think actually because of the way it's affecting the widening of blood vessels, it's quite a common cause of any of the blood pressure medicines. And the other one to look out for is, are they using any over-the-counter nasal decongestants? Because actually that can cause a headache as well, because it's all kind of linked in the sinus area. So yeah, my takeaway message is always ask questions about over-the-counter headaches for someone with an established diagnosis, and maybe be aware of any medicine changes, because that could potentially be a cause of any presented headaches. So I don't know if there's any questions related to that. I'll try my best. I will get back to you with the cannabinoids, because as I say, there's limited information out there on it because they're not a particularly regulated area.
I guess it's just going back a couple slides to what would you do with that person?
Yeah, so the main way to treat that patient is to stop the medication. But that's, if you look at the literature out there, sometimes what they will do is they'll taper with a different analgesic, or they might cross taper like a preventative. But the only real way of treating it is stop it. But it could take up to about 3 months for those medication, that headache, to go due to that cause. So what way, I suppose, as clinicians, if you're managing headaches, what can you do to prevent this happening? This scenario is more about prevention, and it's not.
You go back to why, brought the situation up.
Yeah, it's not on any of my slides. Reduce overprescribing, education. Yeah, it's about education of that patient. It's about telling them that overuse of their medicines can actually make the headache scenario worse, and that it's important that if they're overusing, that they come back to the practice for review to look at potentially investigating further or starting preventative medicines, because there's a lot of medicines we use to prevent like migraines and things like that. How often is normally the recommended maximum amount for any analgesia for headaches and things, particularly migraines? Does anyone know? Can anyone answer that?
As a non-prescriber, I'd always say follow what the packet says, which is what, 4 times a day, milligram.
So yeah, if you're treating migraines, they normally recommend to not take more than 2 days per week if it's for headache. So you're kind of 2 episodes potentially a week, or yeah, normally about 2 days per week. If they're using more than that, then they should be being reviewed for preventative treatment. It might be that 1 week they have it for 3 days and the next they don't use it. But as a rough estimate, 2 days per week. Otherwise, it might cause medication overuse headache, because you're getting into those 15 days per month. So yeah, manage, prevent rather than treat would be my hint on this one. Is it Margaret? Yeah.
Yes, that's nice. So I just wanted to comment on, it's a real kind of paradox, isn't it? Because patients are taking medication for pain, and so they assume it will help a headache and not cause a headache. And I think it's having that discussion with them. And so many times patients will be on come to us on absolutely loads of pain medication, assuming that the only solution is to put that medication up, when actually it's probably going to be not only for headaches, but for other sorts of pain. Sometimes coming off the medication improves the pain, and that's particularly true with opioids. So I think it's that discussion with the patient. Is your medication helping? And with pain and headaches, if it's not making the headache better, particularly that case scenario, she was taking all these drugs and it wasn't making the headache any better. So it clearly is not working. And we can also say that they can make the headaches work. So it's that education, because it goes against what seems logical to the patient, and it's completely understandable that they're doing that. And I think that education is really important for all types of, in my case, pain medication, whether that be headache or anything else. If it's not working, then come off it, reduce it. And then it's the, like you say, it's the education on how to do that safely.
I think something to touch on in primary care is people that are dependent, especially more of the recreational drugs, is using things like change, grow, live. That's not always what we can intervene with. obviously the prescribed medication, but it's making sure that we're aware that we've got that service.
How do you explain to a patient, Sarah? Because kind of going back to what Mag said about patients feeling like they're doing the right thing by taking this kind of simple pain relief, how would you kind of explain to them that?
Oh, that is a really good question. So I'd probably just say that this medicine could be beneficial for their headaches and to take, but it's best taken as needed and to only continue taking it if it is helping the headache thing. But actually, if they're starting to use it more often, it could worsen the headaches, and that's why it's important they come back for a review or to look at alternative treatment options should they be using it more frequently. What I didn't also add on to this was some advice, because some medicines can't be stopped abruptly. So if it's the opiates causing the medicine overuse headache, you might need advice on tapering it slowly, whereas things like paracetamol and ibuprofen could be abruptly stopped. So yeah, just double check with someone with that competence if it can or cannot be abruptly stopped.
I love it. It's a really excellent session, this is, but it's huge aspects of giving knowledge, isn't it? Reassuring people and giving them the safety netting. Those are sort of the three sort of big things. But you know, a bit like your nitrates, reassuring that it's normal. You just started this, but this is how long we expect you to get used to the nitrates, and your headache should ease. But then actually, when they need to be coming back. And not dealing with that constant headache and what to do. Yeah.
I often refer them, I like using the patient.info website as a resource personally, because it's got a really good adverse drug reaction bit at the bottom, and it gives pragmatic advice. So quite often medicines cause stomach issues, and it will say avoid spicy food. If it persists, then seek medical advice, but it's quite, it will say what's realistic and or when to seek medical advice as well. So I quite like that. As a lot of the NHS information is the same as well, but yeah, particularly like the patient.info for the adverse drug reaction bit. Can you stop cocodamol abruptly? Well, that's probably when you need a good history. How much are they actually taking? The problem with cocodamol over the counter is they take more than what is recommended on the package, and it could be, you might want to assess whether there's any signs of addiction or dependency. You should be able to, for cocodamol, you should be able to stop it abruptly, but it will depend on the history, and it might be to get their buy-in, you might need to do it a little bit gradually. But yeah, you should be able to, but I would do it on a case-by-case basis because it's not particularly high doses of opiates. But yeah, it might be that you do it slowly, but only over a couple of days to get it off.
Brilliant. I'm just very conscious of time, so I just have one more main slide in terms of the Nottinghamshire headache pathway. So we've touched on different types of headaches as a bit of an overview, but it's just being mindful. So I know we talked about earlier, like what would you do if you had X symptoms? So this is a really nice kind of flow chart of almost what to do. Now, we're really lucky today. We've got a broad range of professions in the room. But given in primary care now, you could see anything and everything. So what we're trying to do is just enlighten what each profession might do. So kind of as physios, we need an awareness of, say, the medication side. However, we're not the ones that are going to manage it unless you're a prescriber. But then also if an AMP sees a mechanical neck pain, it's that they've got that awareness of when to go to physio, when it needs to stay within themselves. So that's what more the aim of today is, broadening your awareness so that you have a better idea of who needs to be quickly seen, a bit like Kate nicely said, when to reassure, when to safety net, and when to chivvy them along to urgent care and how you word it. So any other final questions, comments? As I said, we've got these next kind of courses, again, very similar principle, and that's where if you've got feedback, please tell us. We want to work with what you need, and we are always happy to adapt, but we're aiming to do kind of themes of kind of presentations and have a chat with the experts. And just so you know, we've got the Grow Knots app, so that's where all the courses go on for lots of things, clinical and non-clinical, and all the resources, again, people that are in Nottinghamshire, how we can help you, and every way you can contact us. But yeah, any other final comments? Otherwise I'm going to stop sharing so I can actually see some people. And obviously it is recorded, so those people can watch back if you couldn't see everything or want to look back. The links are all in the chat from what we've talked about before.
Only thing to add is if anybody has any suggestions of what they would like to have as a discussion point at a later date, please just pop it in the box, and we can really, there's such a great group of professionals that work within the NPSU and within NATH that we can always try to find somebody that can facilitate the conversation. So yeah, just let us know if there's any topics that you'd like to see covered.
So on the 12th of June, we've got one of Mag's colleagues, Danny. So she's going to come in from PICS to talk about widespread and chronic pain. So again, we're looking at that diversity that might show up and the wonderful service that pain team have and how to nicely refer to them. We've also got Pete Gray, who's from the city version. So that's where kind of all Nottinghamshire clinicians have someone in what their local service. But as I said, we're more than happy to take suggestions of kind of other general presentations. So obviously we've done headache, we've done general MSK, and then pain. But you're more than welcome to email us, so we can put our emails in the chat. And otherwise, have a great day. Thank you to our wonderful NATH team.
Thank you, everyone.
Have you seen the Midlands faculty flyer? Everybody's welcome to go to those. These people.
I have emailed it out to all of the AHPs, and I can see it's gone to all the ACPs.
Nice, grand, because there are some there just to stop overlap, and because it's so wide, isn't it? So yeah, please do join them. If you're all very welcome. Well done.
Well,
I really enjoyed today's chat. Thank you so much for coming.
Session. Brilliant session.
I really like the MDT nature of it. It's the first one I've been involved in, but it's just really helpful.
I think it's exactly like having ACP pharmacists and us is so different perspectives. But I think that's the whole point we're trying to encourage, is that first contact practitioner could be any of us.